It's been a real privilege for Goal to be part of this process, which really began with conversations a few years ago. Credit to our colleagues and for collaboration, which brings out the best in all of us. We have 3 really exciting speakers for the first session, and where better to start than at that global sort of challenge of reducing health inequalities and making sure that those furthest behind are at the front of our thoughts. Our first speaker is Sara Burke. You'll see more in your packs about Sara Burke. Suffice to say, Sara is one of Ireland's leading health policy advocates. She has carved her reputation on fighting health inequalities. Her seminal book in 2009, Irish Apartheid, Healthcare Inequality in Ireland, is the textbook on how our health services needed to continue to reflect to ensure that people in Ireland saw an enriched experience of healthcare provision and a reduced experience of those inequalities that so plague us. So I want to introduce and welcome Sara Burke to the podium to start us off.
Thank you very much for inviting me here today, and it really is an honour, if somewhat a surprise, to be invited to kick off this Global Health Forum. Anita Friel very casually asked me to do something at this ages ago, and I said sure, and I didn't think I'd be the beginning of the running order. But I'm particularly interested in the theme of health for all and leaving no one behind. And I think it's a very useful, obviously, to think about this at a global level, but I'm a real believer that we need to learn to do at home what we advocate to do abroad. No, you don't have my slides. Okay, I'll try and find them here. Will somebody else try and do that, and I'll keep going. Okay, I was just thinking in advance of today, because it was Anita and Rory Brewer who both independently asked me to have an input into this today. And in one of those funny circles of life, it's exactly 10 years ago since I started my PhD, which was a PhD program run between RCSI, Trinity and UCC, a program that's become the Sphere program, which I'm now the module lead on health policy and health systems. And it was because of Rory Brewer I have taken this diversion, or perhaps conversion in life. I'm a very reluctant academic. Still feel it's a bit weird to even say I'm an academic, but I'd written an article in the Irish Times about the fiasco of the establishment of the HSE, and out of the blue, Rory emailed me suggesting I apply for one of the scholarships on this new PhD program, and I emailed him back going, I have no interest in academia, go away. And he said, well, let's meet for coffee. And to be honest, the only reason I went to meet him for coffee was because of his surname, and I thought, oh, interesting. A radical academic, very unusual in Irish context, with the surname of Brewer. Anyway, he persuaded me to do it, and actually it was in this building I was interviewed, and it was Hannah McGee, who's now Dean of Medicine here, and Anne Hickey, a professor here, who interviewed me, and I gave a scathing critique of Irish academia and the ivory towers that the academics sat in, and how they/we are part of the problem. And they sort of tossed it back to me and offered me a place on the program and suggested that I become part of trying to solve that problem. And thus it is so I've been invited here today to give this very high-level overview of the Irish health system. How do I do this now? Just tell me which button to go next. That one, okay. And I was told I had 15 minutes to do it, and then somebody subsequently told me I had 20 minutes to do it. So slightly mission impossible, okay, because in the next 15, 17 minutes, I'm going to give you a high-level overview of the Irish health system, and actually I'm going to spend quite a bit of time just on some very high-level indicators of where we're at in an Irish context. And then a recent, again, very much just quick helicopter overview of where we are in relation to policy developments, and in particular the recent Juncture report, which was produced by an all-party parliamentary committee, a Oireachtas committee, we call it in Ireland, on the future of healthcare. Oh, I've forgotten how to do this now. Okay, and this work will draw on the research project that is just finishing up at the moment that I coordinate in Trinity, called Mapping the Pathways to Universal Healthcare, but also my previous postdoc, which was called the Resilience Project, which was trying to benchmark where we were at in terms of what happened to the health system during the economic crisis. So the names on the front slide, it's very much a team effort and drawing on this team's work, not just my work. And as part of this HRB work, very sort of coincidentally, the Oireachtas Committee was set up during that time, and I will talk a bit more about that. But one of its remit was to deliver a plan around universal healthcare, which is exactly what we were trying to do academically. And so the project got delayed because we stopped for 6 months and worked directly with that Oireachtas Committee. So I will also draw on that experience and privilege, really, of having spent 15, 20 years critiquing and commenting and researching and analysing the policy from the outside, of having that 6 months of working also on the inside. I was asked to pitch this like I was talking to an audience who knew nothing about the Irish health system. So apologies to those of you who are very familiar with the issues here. But also sometimes I think it is quite useful for us just to take a step back. And you'll note my previous slide has that much prettier map, aerial map of Ireland. But I guess when we're talking about policy and systems, it is the policy and the system of the Republic in Ireland that most of my research is concerned with. We're a small population of under 5 million people. Our demographics are behind the European OECD norm, so we're slightly younger than the rest of the OECD. We have a higher fertility rate than most of our European partners. We were one of the countries who experienced the worst brunt of the international financial crisis, which became a very severe home economic crisis, driven by external circumstances, but also really poor public fiscal and economic policies of consecutive governments in Ireland. And there was huge cuts across public expenditure, but it was actually health that bore the brunt of those cuts more so than any other sector. And then what we've seen since 2015 is this huge escalating economic growth, again breaking all international growth rate norms, which I think seems odd to people who are living here because it mightn't feel that. But when you look at our figures, our GDP rates of growth are very high and slightly similar to how they were pre-bust. In terms of our health system, and I don't think I can say it enough, we have no universal health system in Ireland. There's no legal entitlement to health and social care, and we have this extremely complex system of eligibility that has its origins in legislation written in 1970, so nearly 50 years ago, but actually has its origins in the Poor Law, which was imposed on Ireland in 1838 by our British rulers, and very much produced a poor system for the poor people. And I think that helps explain some of our inability to get out of that and develop a universal health system up to now. The 1970 Health Act divides the population into Category 1 and Category 2, which is basically people who are poor enough, usually to have medical cards, about 1/3 of the population, and 2/3 of the population who don't have medical cards. But actually it's much more complicated than that, and there's layers and layers on top of it. But the most notable layer when I'm presenting internationally is that nearly half the population have private voluntary health insurance. So we've extremely high rates of uptake of health insurance for a system that is not compulsory. And actually a health insurance system that buys you very little. And this is pretty much the same slide as previously, but it's just showing you the breakdown of our publicly funded system, or of our entire health budget. So just under 70% is tax funded. Sort of depends which stats we use, but this is WHO stats, which show about 15% is out-of-pocket spending, 15% is private health insurance. And within that, we have high health status inequalities, but high unmet need and poor access. And this is our composition of health spending across I think it's the European 28 countries for 2014, just because that's the only one that's currently available. And again, that shows that solidarity funding, or public funding, well below the EU 28, where we're ringed there sort of in the bottom half. And that's because of our high out-of-pocket expenditure, but also high uptake of private health insurance. So when you hear our political leaders say we've a very expensive system of healthcare, they're referring to the overall expenditure in health rather than the public expenditure in health. And when you look at our public expenditure in health, we're still below or about the EU norm. Just in terms of health inequalities, our life expectancy has increased significantly over recent decades, reflecting improvements in quality of life and the determinants of health. We're now above the EU norm of average of life expectancy. But as you can see from the bottom of this chart, we still have these significant inequalities between rich and poor, with 5-6 years difference in life expectancy between the people on the lower socioeconomic groups and the people on the higher socioeconomic groups. And this inequality has persisted even as inequality or our life expectancy has increased. We have extremely high levels of unmet need, which aren't always caught in survey data, and there's lots of reasons for that, but part of it is we always rate ourselves. When everybody self-reported health in Ireland, the general answer is, sure, I'm grand, even if you're not grand at all. So there's real problems with our unmet need data, but there is recent better data, which is the European Health Information Survey, which shows that we've the second highest unmet need for healthcare across Europe, way above the European average at 40%, the European average at 26%. And what this chart shows at the bottom is just that unmet need for all aspects, or many aspects, of health and social care. So for medical care, which is hospital, outpatient, GP appointments, dental care, mental health care, and prescribed medicines. So huge amounts of unmet need. And in terms of access, and again, it's difficult to get time series reliable data over time, but we have some, and this is your first outpatient appointment. So this is the time when you go to see your GP and your GP decides you need to see a specialist, to that first specialist appointment. And the HSE changed how it counted this. They sort of stopped counting. The figures were so high in 2009 to 2010, they stopped counting and then they started again, but they're not, you can't continue the series. So we have to start in 2012. But what this shows is hundreds of thousands of people looking for care, and the international norm is 0 to 3 months, that it's okay unless it's an emergency to be seen within 3 months. It's considered a reasonable period of time. And the green is the 3 months, and you can see there the green is rather steady. But what's increasing is the 3 to 6 months, which is the blue, the 6 to 12 months, which is the red, and the over 12 months. So this is for your first appointment with a specialist when you're sick and in need of diagnosis or treatment. And this shows about 130,000 individuals waiting for that first appointment. Our waiting list data is appalling. It wouldn't pass any benchmark of international best practice, because we have various different waiting lists rather than a whole waiting list time. And so this is the data from when you get to see your specialist and you're determined that treatment is needed, which is about 1 in 10 of those who go to a specialist. So these figures, the N is much lower, it's 80,000 people. And again, the 0 to 3 months, the green bar is within the absolute norm. But it's the blue, red, and yellow where you're waiting months or years. And if you combine those two, you will see that hundreds of thousands and tens of thousands of Ireland wait years from diagnosis to treatment within the public hospital system. A lot of the work I've done with the Pathways project has been in an EU context, and they're always, with the WHO, and the WHO are always trying to get us to fill out this box for Ireland. And it ruined a summer of my life because I couldn't work out how to put that into a 3D box, right? And actually, the content in it is irrelevant, right? But if we just go very briefly back to it. So this is like, under a universal health system, who is covered? So it's universal, everybody is covered. So how do you move to everybody being covered? What services are covered? And how financially protected are citizens for achieving that care? And what this was is sort of a snapshot in time of what it was like 2016, 2017, actually I updated it for the Oxfam report, but really the only aspect of universalism within the Irish health system is our vaccinations, our screenings, and the maternal and infant care scheme. There's no other aspect of it that is truly universal. And in terms of why this is important, we know that this unequal system of care, that the inverse care law perpetuates inequalities, that it creates poorer outcomes for people. People with delayed diagnosis need more medical intervention that's more costly, but also detrimental to their health and their quality of life. But in some instances can be fatal, that delayed access to care. And we are extremely unusual in an OECD, European context that we have no universal primary care, that we directly funnel people into the most expensive places to get care, usually the hospital system, that we have a system that incentivizes doctors and hospitals to treat private patients even within the public hospital system. We've high unmet need, poor financial protection, and there's this, so people say that a medical card actually protects the poorest, and recent research we've done in Trinity around financial protection shows that actually even the smallest of charges introduced during austerity has pushed the poorest into catastrophic spending and financial hardship. Okay, now I spent way too much on that because I have 5 minutes to go. Okay, so we've got to speed up. I just throw this in as a last one, which was what happened during the economic crisis. And what it maps is the two bottom ones, the red and the purple, is the cuts to the budget and the staff. So there was huge cuts to public budgets and public staffing. And what the other lines show is the yellow at the top is a huge increase in day cases. So we did way more day cases, triggered really by the financial crisis. Inpatient care sort of leveled off. But the only bits of the health system that didn't stop, didn't level out or go down were emergency presentations and emergency admissions. And so this slide tells us lots of things. I could actually spend 2 hours on this slide, but the sort of key messages is that the system actually did manage to do more with less in the first few years of the crisis. And then it got to a point where it had no choice but to do less with less, except for the areas where it couldn't stop people coming in the door, because happily in Ireland, if you present for emergency care and need it, you will get it. But what's beneath all this also is that actually we've made significant improvements in care during this. So I know I've painted a pretty grim picture with this high-level overview, but there have been significant improvements in cancer services, in palliative care, in stroke services. So against the odds, many frontline clinicians and teams have managed to improve care within the public system in this extremely difficult environment. And if we are to sort of trace Ireland's health policy development, we can probably see 2 or 3 or 4 different eras. The 2000 to 2009, where there was a quadrupling of the health budget, this constant reorganisation of structures without any real reform, and this very silent but effective privatisation of huge aspects of healthcare. And then 2009 to 2014, a system sort of paralysed by austerity that put more charges onto people, that increasingly rationed care. And very ambitious reforms, one of which was universal health insurance, happily were not realised. And then from 2014 to 2016, this stabilising of the health budget and the development of this all-party committee on the future of healthcare. And we're in this potential area now of increasing health budgets, and with Sláinte Care there as a policy document, and that's why I say we're at this critical juncture. I have 2 minutes to give you your crash course on Sláinte Care. Okay. Again, don't worry about the detail of this. Basically, the committee was set up after a general election when, in short, nobody knew what else to do about health. So let's set up an all-party committee and give them a remit to develop a 10-year plan to devise a universal health system. They reported a year later. For 15 months, very little happened and in August and September of this year, the Department of Health produced a response to it, which is a pretty shoddy implementation strategy that I gave a good critique to about 6 weeks ago, and I'll spare you the detail of. And they have set up an office to drive that reform. And key to Sláinte Care are these 4 areas. So bringing us up to the norm about legislating for an entitlement to care, but also around wait time, so that you're not entitled to a service that you can't get, that you'll get that service within a period of time. Huge reorientation and a boost for the system towards primary care, much more services outside of hospital, much better public health, much more integrated care with the person at the centre of it, facilitated through workforce expansion and critically e-health, a costed plan to do it, and an implementation office to drive the reform. And one of the elements in there is the removal of private care from public hospitals. The vision was kept in the implementation plan, and some of the implementation plan is quite good. It's strong on public health, it's strong on non-hospital care, it's quite good on an implementation structure. It has good new ideas around a citizen care master plan, mobilising people to get behind the need for health reform, and critically, the engagement of people working in the health system, people who are weary and tired from constant reform, from huge media and public bashing, and getting them to drive the reform, because we know health reform works, only really works, when you have that leadership from the front within, or from the bottom within the health system. So, I was really struggling with how optimistic or pessimistic I could be today, and I've tried to steer it somewhere in the middle. We've never had political consensus on health reform in Ireland, so it is a huge achievement that there is a plan there that was devised by politicians, and it is a roadmap to deliver a universal health system. So it's the first time in the history of the state, we're nearly 100 years old, and it's the first time we have a plan to deliver universalism. There is an office with a great woman at its helm, and momentum to drive that reform, and commitments to engaging citizens and staff within the system, and I think that's really positive. But within the Department of Health response, there's also a backtracking on universalism, and instead of using the word entitlement, they go back to the 1840s or the 1970s language of eligibility. It's like they just don't understand it. It's much less ambitious in terms of the politicians' report was getting some quick wins, getting the people on board and driving the reform before the vested interests gathered and stopped it. And there's been quite a bit of long fingering in the new report. The budget allocated for next year is nowhere near what's required to implement Sluntcha care. So in conclusion, we know that reform of this kind is hard to deliver and will be and is being opposed by vested interest, and that in a way it's easier to stay on the inefficient, unequal track we're on. We know that past dependency, that previous form, is a very good predictor of future performance. But I'd argue that we've no choice but to reform, that our current system is unsustainable, it's unfair, and it doesn't deliver the health and social care system that those in Ireland should expect and be entitled to. That said, we know that policy change to reduce health inequalities, to tackle inequalities in access to services, to deliver universal healthcare, requires progressive action. It requires really active action, that's a terrible word, progressive action, which can only be realised through enormous political courage, commitment and momentum. And I do think we're at a critical choice in Ireland, where we as people, as citizens or people who live here, have a chance to influence our political leaders to choose the opportunity that Sluntcha care brings to break from the path we're on and work towards a universal health system for all, where no one is left behind.
I would like to share with you the story of Malawi. So basically, I'm talking about our journey in terms of achieving universal health coverage. I'll talk about the successes that we've had as a country and also the challenges that we've met in the process. So I'm talking about Malawi. Glad that there are a number of people here who've been to Malawi or who work with Malawi or who know Malawi. So it's called the warm heart of Africa. It's a very beautiful country, very nice scenery, very nice people, and yeah, very beautiful all in all. Yeah, so I think coming to the basics about the country, we were a British colony. We got independent in 1964. We have quite a big population of about 17 million people. Our economy is dependent on agriculture, and it's mostly rain-fed agriculture and largely subsistence farming. So basically, the climatic conditions that have been happening recently, the global warming and issue, have got quite a big effect on our climate and on our agriculture productivity. Like for about the past 5 years, we've had droughts or floods, which have really affected our production. We are a relatively poor country. Our GDP per capita is 1,200. IMF ranks us one of the third poorest country in the world. About more than 50% of the population live below $1 a day, so that's that's the poverty line. So actually, the figures go. Some estimates are even much higher. Life expectancy, according to the UN, it's at 54.8%. Of course, there are other bodies that peg it at a different rate. So I've used the UN rate. And then, as a country, apart from really being a poor country, we've had a big challenge of growing in inequalities. In just a period of 7 years, the gap between the richest 10% and the bottom 40% has grown by almost a third. And it is estimated that if nothing happens, by 2020, there will be 1.5 million more Malawians being pushed below poverty line. Okay, so basically my talk today, I basically want to defend my and Oxfam and other CSOs' idea that universal health coverage, its achievement or lack of it, it's a matter of choice. It's not really an economic issue. For me, it's rather a political or an issue that we decide. We decide whether we want to achieve universal health coverage or not. And even for a poor country like Malawi, there are decisions which we can make working towards universal health coverage. So I think the first picture that I would want to push is that as a country, we've done some decisions that have made us to choose not to leave anyone behind when it comes to universal health coverage. I think the first thing that we are proud of we are proud of as Malawians is that I think there have been times when we've resisted to pressures by other institutions that have maybe really suggested measures that we feel would leave other people behind in terms of universal health coverage. For example, around the 90s, the late 80s, 90s, when there was that push during the structural adjustment programs around around countries introducing user fees for health, Malawi as a country, we decided we are not going that way, and we feel it made quite a significant improvement in terms of our health, our journey towards universal health coverage. So I think, therefore, since we made that decision, we've been financing our health system mainly through tax and donor aid. And generally, what it has meant is that health services is free at the point of access. So if I go to a public hospital, I do not have to pay anything to access health services, which for a country like Malawi, where a majority of us are poor, it is very important to have free access to health services. And then, apart from that, we do appreciate that there are some sections of the country that are not covered. Government has gone on to make service level agreements, mainly with health facilities that are provided by a Christian NGO group. So whereby what happens is that for every facility that is not covered or that is outside the government covered area, so that's for the radius of 8 kilometers and having a population of about 7,000, government pays these private facilities to provide health services, especially the essential health services to the public. And then the other thing that Malawi chose was basically the choice to have an essential health package. So basically, Malawi has a package of health services that are mandatory to be provided at every facility. So this package has got like it has got things like treatment for basic common illnesses, HIV, some non-communicable diseases, maternity care. So it is a package that is mandatory and really guides the services that each health facility can provide. Secondly, the government has really, in terms of our health strategic plan, it has been clear and it has been deliberately put in place a policy that works towards achieving universal health coverage. So universal health coverage tops the agenda. As you can see on the far right, that's our strategic health strategic plan covering 2017 to 2022. It clearly has towards universal health coverage as part of the agenda. And I think because of that, that's why I think as a country, despite our economic situation, we were able to achieve MDG4, which is around infant mortality, much faster than our neighbors. And then, having said about the progressive choices that we've made as a country, there have been situations where we've also made some choices that haven't been good. I think one of the things is that as a country, we've not been very good at curbing corruption. There are big levels of corruption in the country. Like in 2014, there was a big cashgate scandal where a lot of money was siphoned from the private coffers, like directly from the central government. So I think that that also led to donor withdrawal of direct budgetary support. So it was basically a decision that government made so that they're putting less effort in curbing corruption, and then it is affecting aid, which is a big contributor to Malawi's health financing. And then also there has been less commitment by government to address inefficiencies in health service delivery. There are high cases of drug pilferages, high cases of pure procurement inefficiencies, and a lot of other inefficiencies. And I think as a result of those poor choices, we've had poor health service delivery, inadequate drugs and supplies, and also inadequate staff in the facilities. Okay, and then also further, going further in terms of the retrogressive choices, because of the dwindling public resource, government is now exploring a lot of other retrogressive means. For instance, there's been there's been a lot of exploration around user fees in the health facilities. Like you can see on the newspaper caption, there's been to and fro battle in terms of exploring hospital user fees. And currently what government has introduced is a bypass fee for health facilities. So basically, there is a requirement that everyone should be going to a primary health facility, and then they should be referred to a tertiary level facilities. But what happens in my country is that in most cases, there are some areas that are covered by a tertiary facility that do not have a primary health care facility. And then apart from that, the primary health facilities are generally not functional. You find that there's inadequate staff, inadequate drug. So by the end of the day, they're asking people to pay about 2 to 3 euros if they want to bypass the primary facility. However, because of the poor condition of the primary facility, basically people are forced to bypass. Otherwise, if they do not bypass, it means they're missing out the health service at all. So basically, that is the situation. So basically, this bypass fees which has been introduced is somehow pushing the already poor people further into poverty because they're being forced to pay while the facility which is being proposed to cater for them is not functional. So basically, looking at the out-of-pocket mechanisms that are being proposed are basically fueling economic inequalities because people now, the poor, have to spend much bigger proportion of their wealth on health expenses, and then they are negatively affecting the redistributive potential of health investments. And then in terms of going further, in terms of the retrogressive choices that my government has done, one of the key things is the decrease in budgetary allocation to health. Malawi is a signatory to the Abuja Declaration, where we made a commitment that we are going to at least allocate 15% of our national health budget to health. However, over the past years, that hasn't happened. You can look at the graph there. In 2013 to 2014, we were 12%. But over the years, we've been decreasing to below 9%. So that is a big challenge. And then I think the retrogressive choices haven't just been made by government. When you look at donors as well, donors now have chosen to do an off-budget support. So it basically means they've got their own priorities, and sometimes the priorities do not match the government's priorities. So that is also affecting health service delivery in the process. But also, I think as a country, we've chosen to maintain retrogressive treaties that are supporting developing countries. Like, for instance, Malawi has got treaties with countries like the UK, the Netherlands, Norway, and France that basically exempt those countries. Goods produced in Malawi exported to those countries, they are exempted from tax. And basically that tax could have some significant support towards provision of essential services such as health. So basically we are saying that the fact that we are accepting those treaties to go on, and mind you, these treaties were negotiated during the colonial era. So they are not recent treaties. They were negotiated during the colonial era when the bargaining powers were very unequal. And then I just wanted to share a bit in terms of, after looking at the context, there's a lot that us as civil society organizations, so Oxfam and our partners, and I think on this work in terms of Oxfam, we are mainly supported by Irish Aid in terms of what we are doing as civil society organizations. First of all, we are working together with other civil society organizations to make sure that we are working with communities and make sure that we are helping them to make demands. Currently, the situation in my country is a lot of decision makers make decisions that do not necessarily favor the poor people. So you really need to have citizens' action to make those demands if we're going to have good access to health services. I'll show a brief video about that, around that. Just a minute, yeah. And then the other thing that we are doing, sorry, thank you. The other thing that we are doing is that we are doing a lot of advocacy. So we formed, we've mobilized ourselves into our Universal Health Coverage Coalition, where as CSOs we are coming together and advocating for universal health coverage. And also we are doing a lot of research and getting information to inform our health policy suggestions. We've had a number of students from the Trinity College supporting us. So there are 2 research papers that have come from Ireland and from Trinity College that has really informed our policy action around health. So yeah, briefly, I'll show you a video. It's basically around how we've worked with communities to make sure that they are demanding an address of injustices that are happening in terms of access to health services. Basically, some of the key issues that we are calling for is that one is we are calling for our government to make sure that they commit to spending at least 15% of our national budget on health. We are calling on them to make sure that they put in place systems that ensure efficient use of resources and curb corruption. We are calling for putting in place strategies that are promoting progressive tax reforms to make sure that we are able to redistribute our economy so that we're able to cover services for the poor people. And I think key, we are also calling for our government to renegotiate the treaties that disadvantage our countries. However, the call is not just to Malawi. We are also calling upon our donors to do a number of actions. First of all, we are calling for them to support the financing of healthcare through stronger and more equitable tax systems, including through collaboration to tackle tax dodging. I think there have been a number of cases in my country where where some institutions do dodge tax. So I think we are really calling for that. We are calling for reform in the donors' home policies around tax dodging, and especially around negotiating to remove those retrogressive tax treaties. And also there's a call to make sure that the donor communities are channeling aid through the government healthcare system, and that they're working to support the strengthening of public financial management systems and generally to advance the aid effectiveness principles.
Lovely hearing Lusungu. I had the good fortune to work in Malawi heading up our development programme from 2014 to 2016, and whether we met the challenges and the suggestions that Lusungu put out there on the second last slide, I'm not too sure, but let me, in the next few minutes, what I'd like to do is share with you an ongoing process to review our international development policy. I'd like to share a couple of slides on one of the key issues, I think, in delivering universal healthcare, and particularly in reaching the SDG goal 3.8, delivering universal healthcare to everyone. And then just a last couple of slides on what it is we're doing in the health sector and our thoughts going forward on what it is we might do over the coming years. So, yeah, that's what I'd hope to do. Right. Yeah, the revision of our international development policy, our present policy dates back to 2012. Last year, more or less this time last year, October, on Budget Day, the Tánaiste, Minister for Foreign Affairs, Simon Coveney, announced the clear intention of the government to move to 0.7 by 2030. That 0.7 commitment, it's something we all signed up to in 1979, a little while back. Some countries have got there. There's about 6 or 7 countries who deliver on that 0.7 commitment year on year. In moving to that 0.7 commitment, the Tánaiste was anxious to have a good development policy to guide that whole process. So working off the DPAR, the Department of Public Expenditure Reform guidelines for formulating new policy, we started into a process, a year into it at this stage, and these are kind of the key milestones in that process. Starting with internal analysis, reaching out to a lot of our colleagues here domestically, reaching out to the 7-8 departments that we work most closely with. That brought us up to May, June. We then got a consultation paper together and then went on the public consultation process. And the public consultation process, we have received 185 substantive written submissions, and I'll give you detail on where they came from. We've got about 14,000 other contributions, mainly through social media. And then we did a number of public consultation meetings, town hall meetings in 5 different locations. I think the breakdown of those 185 submissions, the majority coming from Irish networks and NGOs, next 17% from international networks, NGOs. In total, I think all the submissions, they amounted to about 1 million words. So we're trying to distill that and pull up the best of what is there. The general response from the consultation process, a very warm welcome for the commitment to 0.7 and trying to get there. The centrality of the SDGs, the previous policy had predated the SDGs, so yeah, we need to put the SDGs front and centre in what it is we're trying to do and deliver. The authenticity and the coherence of Ireland's international actions was recognised, and the kind of proposed priorities that came out of that process, or that's coming out of that process, definitely that whole commitment to leaving no one behind, but we've kind of gone another step with that. Leaving no one behind, you're looking at a community, you're saying, well, who's left behind? You're probably looking at 40, 50, 60, 70% in some cases. What we've committed to is to continue a very clear focus on the poorest. So we're working more with this furthest behind first, trying to ensure that we get the furthest behind first and prioritise those in our work. Clear commitment and a lot of recommendations around gender equality, keeping a focus on gender issues. Climate change really came up a lot, so how we might respond better, build on our existing work and respond better to climate change. Reducing humanitarian need, and then governance and human rights. And the kind of interventions that people were encouraging, a lot of this we're doing already, but a definite focus on peace, hunger and agriculture, education and health. Some of the challenges that were highlighted during that consultation process. Around protection and prevention, respondents are looking for bold action on fragile states. And possibly commitment to engaging, for example, in South Sudan, a crisis that we have funded for a long time. So we put in humanitarian support in South Sudan. We're putting in about 6 million a year, but we don't have a presence there, and we're not getting in there following that money and seeing what's happening on the ground. So kind of, can we up our engagement in fragile states such as South Sudan? A lot of the contributors highlighted the shrinking civil society space. Civil society within a lot of countries is under increasing pressure. And yeah, a need to be aware of that, and calls for Ireland to take a leadership role in addressing that issue. The movement of people, refugees, and European politics around aid loom large. The whole refugee crisis has challenged what it is we've been doing in aid, and a lot of our money now is heading into addressing the migration crisis. I think it peaked in 2015, I think it was, with Syria. It's dropped back considerably, but it's still a key issue going forward. On food, we're looking at taking a kind of a systems approach to supporting people, a systems approach to addressing the food challenge, the nutrition challenge that is there. So that's looking at, in the context of food, what it is that countries are producing, people's access to it, how those markets are working, are those markets working for the poor? And yeah, how do we address the root causes of hunger? Can we improve what we're already doing? There was a series of suggestions around how to harness Irish experience and expertise. We've come on a very interesting journey here in Ireland in the last 50 years, coming almost from subsistence farming, now exporting food, feeding, I think there's different figures used, but up to 40-50 million people globally with our beef and dairy. A stronger focus on women, again under that food heading, it was called for, and submission to attention to the future, technology, urbanisation, young people, inclusive economic growth demands that we look at these issues in a lot more depth. On the people focus, in health, a focus on bringing people-centred community-level approaches to the fore. In education, accepting that education underpins everything in development, there were a range of proposals for sharpening our focus for impact in the education sector, and a need to do more on development education here domestically to kind of make people more aware of our development efforts and to garner and ensure broad public support for what it is we're doing overseas. So a lot of what we're looking at doing a lot of what it is we've been doing to date, but we will be trying to do it differently, and we'll be trying to do it in a way that has greater impact. So some of the suggestions around that, a clear articulation of rationale, principles, allow the programme to grow in a sustainable way. By reaching point 7, presently we're at point 3. If we're to reach point 7, and point 3, equates to about 700, 800 million a year. If we're to get to point 7, our budgets will grow to between 2 and 2.5 billion by 2030. That's a lot of growth, a lot of expansion. We need to do that in a way that we can manage well and that we can deliver well with. Policy coherence for development, this is a key issue, I think, and it's one thing, the budget that we have, so at the moment it's 0.3 of the national budget. We can do very, very good development work, we can deliver on climate, we can deliver in all these different areas. It's 0.3 of the budget. If the other 99.7% of the budget is going in a different direction or isn't delivering on the SDGs, then yeah, it has to be. The SDGs bring that reality that it has to be a whole of government approach. Cross-government coordination, key, balancing innovation and risk management. We're being challenged to do a lot more with the private sector, and we want to meet that challenge, but we want to do it in a way too that we manage risk. Handing money over to the private sector, public money to private sector, how it's done well, and how it's done in a way that has good development impact. That's a challenge going forward. Strengthened culture of learning, trying to use our research better. I've mentioned the focus on furthest behind first. And I think too, a key lesson, we can't deliver well on all 17 SDGs, so trying to focus in on a smaller number and deliver well on that smaller number. So that's kind of where we're at. We would expect the policy, would hope to have a first draft in the coming weeks, and we'd hope to have a policy to share with the public in early 2019, all going to plan. So this slide, these are some of the figures. Some people have mentioned the finance issue, but I think these figures are pretty stark and pretty important. They're a little bit dated. They're from they're WHO figures from 2015, and in Ireland, we were spending $4,757 per capita, and we weren't. Whereas Sara has very clearly pointed out, we're not delivering universal health care or coverage on that budget. And then when we look down at what we call our KPCs, there's 8 countries that we focus a lot of our efforts on. Look at their budgets per capita spend on healthcare. Malawi, just alluded to there. Those budgets are minuscule. You're trying to deliver universal healthcare for $34 a year per capita. In Ethiopia, $24. So some of the countries that are kind of heading towards middle income status, they're maybe on $60, $70. I think the WHO, the most recent figure I could find on this, they suggest that you need about $44 per capita to deliver some semblance of universal health coverage, very much primary healthcare focused. So a lot of them don't even reach that. And those figures again, yeah, it's stark. My first assignment with Irish Aid was in Ethiopia, and as part of our support to Ethiopia, we used to deliver about $1 million a year to 2 of the districts, one in the north and one in the south, Tigray in the north, SNNPR in the south of Ethiopia. And on an annual basis, we would get their report on what they had done with our 1 million in the previous year, and then we'd negotiate what it is they would do for the following year. Straightforward enough. And my counterparts there, Dr. Shifaru in the south, Dr. Thiedros in the north, we'd sit down and we'd try and make that budget stretch, and we'd try to do the best thing possible with it. And what I would say, coming out of those processes and having been engaged hands-on for that 3-4 years, the value that we got for that money, it was minuscule money, but what we got for it was astounding, particularly in Tigray in the north, where they had a very, very good primary healthcare system. A lot of it dependent on volunteers and community health workers, but it was amazing what we got for that money. And I had no problem defending the money we were spending and arguing for more money. But more money, yeah, it's quite limited with what we're getting. Just to move on from that as well, this is trying to look at the spend and the need. So here, that may be hard to see, but just to give you for me, the takeout from that, the OECD countries, the 36 OECD members, the rich club, if you will, we spend about 82% of the global health spend. And we have about 18% of the population. And then the green little thingy there is the disability adjusted life years, basically the kind of disease burden or an indicator of the disease burden that are in those countries. So Africa is there on the left. So you're seeing they're accounting for about 1% of the global health budget, and they've got about 24% of the global health need, if you will. Oops, I'm in the water. And then, sorry, the red line in the middle is the population issue. And again, just to put it in contrast, the Ethiopian budget for health, back in 2015, I tried to dig out that figure, it's about 2.5 billion. And that again, so it's 2.5 billion to deliver healthcare to a population, they've just topped the 100 million recently. And here we are at home, struggling, trying to deliver healthcare to 4.5 million people on 16 billion. That's a hell of a contrast. But yeah, that's the challenge that we have and we face in our development efforts. So when we get out there and when we engage with these health systems, trying to get value for money, But I would argue as well, it's hard to make that money stretch to do what it is we'd like it to do, given the volumes that are there. I didn't take Rory's advice to switch off the phone. No. Caught rapid. Anyway, look, what about all of this? I thought it is something that I should throw out there at this opening session. I think these are some of the kind of, Sara mentioned earlier, I think, some of the issues, and finance is one. It's key, I think. I'm just conscious. I think the global health budget is about 7 trillion. It's probably enough to get us to deliver UHC, but it's where it is, how it's spent. I think there's a need to have a real good look at that. Right, moving back to our health engagement. Just to say a few things on that. Our support, our focus over recent years has been on building health systems, strong focus on immunisation and human resources. Also supporting the development of products to prevent and treat diseases of poverty, a lot of the neglected diseases as they're called, putting money into that. Building capacity and fostering collaboration between Ireland and the KPCs, and I've just mentioned some of how that happens at country level. Mobilisation of Irish domestic partnerships. Again, there's a huge value in that, I think, and we can bring a lot from Ireland to the developing countries. Improving the effectiveness and efficiency of the Global Fund for Aid, Tuberculosis and Malaria. That would be our biggest financial commitment. And reducing vulnerability and empowering women in the fight against HIV and AIDS with a focus on prevention. Those are kind of the key areas we've been working on. Again, how we deliver that, it's the country programmes in KPCs. A lot of those would have a health component. At head office level, the global health and HIV AIDS partnerships that we've been focusing on, as I said, GFATM being the biggest, 14.5 million in 2018. Product development partnerships, mainly Gavi with that, 3.275 million. And then the domestic health partnerships, about 635,000 a year. And also then civil society partnerships, working with the likes of Oxfam, Concern, Goal on their health work. Health expenditure. Health is the second largest area of expenditure after our humanitarian support. It's dropped a little bit over the recent years. It's kind of steady now at about 80 million a year. And I'd like to think, again, as our budgets start to grow and as we start moving to 0.7, that we can get that going in the right direction again. Future priorities, maintaining political and financial support for universal healthcare, ensuring no one is left behind, and as I said, going a little bit further than that and putting the furthest behind first. Increasing support and follow-through commitments to health system strengthening and sustainability. I think a maintained focus on health system strengthening. And then a strong focus on key at-risk and marginalised populations, and strengthened support to reproductive health and family planning, just as there's been a lot happening in that space, US, the whole lot, and trying to see, and with our recent referendum, it kind of changes our position too on some of these health issues, so there may be an opportunity to expand and do a little bit more there. And that whole of government approach to global health and HIV/AIDS, just trying to ensure that we deliver a coherent with what we're doing nationally. Ideally, we'd be delivering universal healthcare nationally before. I'm always happiest out there advocating for things we've done well at home, rather than stuff we haven't yet delivered at home, and we're trying to get partner countries to move on. But hopefully we make more progress domestically and we can push harder internationally as well.